And one important point is that anti-Rho negative populations are actually more likely to have positivity for anti-centromere antibody, an antibody that's now gaining interest in the diagnosis of Sjogren syndrome, in addition to its importance in other diseases. Anti-Rho positivity by itself is again associated with positivity of other antibodies, and that includes rheumatoid factor and anti-CCP. It is also linked to hypergammaglobulinemia, and all patients who are anti-Rho positive are more likely to be anti-LA positive as well. So one may wonder if we should check for the anti-LA positivity in the presence of anti-Rho or just depend on one of them. Does anti-LA really matter? So here is a study with the large population that was done by Bayer involving more than 3,000 subjects of Sjogren syndrome. And in fact, if you look at those columns, those patients who are actually negative for anti-SSA and anti-SSP did not really differ, whether we're talking about the clinical characteristics or objective evidence, from patients who do not, who simply, have the SSP positive antibodies. So in another way, if you have SSP, it's just similar to having no antibodies at all. Again, this was documented in the serological markers as well, including the hypergammaglobulinemia and the presence of rheumatoid factor. And that's why in the recent criteria, unlike the old ones, the anti-Rho is the one that we depend on rather than the anti-LA antibodies. Rheumatoid factor, a well-known antibody that is present in Sjogren syndrome, it is again associated with female predominance and younger age. Positive salivary gland biopsy, and of course an active serological profile, including the presence of cryoglobulins and hypergammaglobulinemia. The presence of rheumatoid factor, not surprisingly, is associated with the presence of articular manifestations, in addition to the other involvements of cutaneous vasculitis, salivary gland enlargement, the cytopenias, renal phenomena, and renal involvement and CNS involvement. Interestingly, for the renal involvement, the rheumatoid factor that is associated in Sjogren syndrome is not the IgM antibody that we commonly see in rheumatoid arthritis, but rather the IgA rheumatoid factor. This rheumatoid factor, in addition to association with renal disease, has independently been associated with the presence of other antibodies and their level, in addition to the presence of a focus score in a minor salivary gland biopsy. Now we come to the other antibodies that are not commonly commercially available, but are very important in Sjogren syndrome and are actually gaining importance in the disease. The anti-alpha-fodrin antibodies, which are directed against alpha-fodrin, which is found in the cytoskeleton of cells. So it's not surprising that the more destruction of the tissues, the more lymphocytic infiltration, you're more likely to get an increase in anti-alpha-fodrin. And again, this is seen in the shorter disease duration and earlier disease, so we might have it of importance in people who are gapped, i.e. they have not yet developed anti-SSA antibodies, for example. Anti-Sjogren's antibodies, who were initially previously described in the mouse models, are now being described in the salivary glands themselves or in the secretions of the saliva. They include three types, which is SP1, CA6, and PSP. So they're basically directed against antigens in the salivary gland. The most common being the anti-salivary protein 1, which is highly expressed in the submandibular and the lacrimal glands, to a lower extent in the parotid and the submandibular glands. The anticarbonic anhydrase that is expressed in the submandibular and the parotid glands. And least commonly is the parotid secretory protein. Again, both of them actually serve as viral attachment sites, so it's important to remember that when thinking about autoimmunity and the link to infections. Now, this is actually when they describe the association of Sjogren syndrome. And I'm sorry I don't have a pointer, but if you look at the B population, which is on your top right, these are simply people with Sjogren syndrome who are positive for antibodies of LA and Rho antibodies. C is actually how those antibodies, which are the Sjogren's antibodies, appear in the normal population. D is actually patients with rheumatoid arthritis. E are those people with early xerostomia who are not Sjogren syndrome. But then look at F. F are those people with early Sjogren syndrome who are seronegative. And this is where the major importance of those new antibodies accounts for. In fact, there were two other studies involving 20 patients and 29 patients showing that you are more likely to have positivity for anti-SP or salivary protein 1 antibodies and carbonic anhydrase antibodies in cases of early xerophthalmia and xerostomia, that is before 2 years of the actual diagnosis of Sjogren's, or if you have Sjogren's in the earlier stage or you are seronegative with Sjogren's. Again, the importance, see that 13% are those people who are actually anti-SSA and anti-Rho positive. negative. So this is where it accounts for. The more negativity for anti-Rho and anti-La, the more positivity you get for anti-Sjogren antibodies. The antimitochondrial antibodies that we all know as part of primary biliary cholangitis are also present in Sjogren syndrome, and they're actually present in up to 13% of those population. Not only is it associated with liver involvement, but there is also an association with Raynaud's phenomena and peripheral neuropathy, a higher ESR, that is an ESR more than 50, hypergammaglobulinemia, and in fact, not surprisingly, it's associated with the development of autoimmune cholangitis. Now, this is the antibody that we talked about, which is anticentromere antibody, commonly described in scleroderma patients. Again, it has been seen in Sjogren syndrome with a prevalence of up to 27%. However, the antigen that it recognizes is different from that recognized in scleroderma, i.e., it recognizes the C part alone. It is also associated with Raynaud's phenomena and keratoconjunctivitis sicca, peripheral neuropathy, and the concomitant presence of autoimmune diseases, of course, namely scleroderma. Anti-CCP antibodies, which are well known for rheumatoid arthritis, have been described in Sjogren's, but there is controversy about them. In some studies, it did not correlate with any demographic features or sinusitis or even extragranular manifestations. However, in others, it did correlate with non-invasive synovitis and the articular symptoms. There is also, of course, discussion of whether those patients who have articular symptoms are actually rheumatoid arthritis with secondary Sjogren's or truly Sjogren's with just peripheral arthritis. So what is ideal? Having known all those antibodies, what should we check for to know that the patient has Sjogren's? There are several theories about that, knowing that the complexity of antibodies can actually alter your diagnosis at one point, and you should mainly depend on your clinical sense for that, not to be confused with the presence of antibodies only. So Shen proposed that the first step is actually to look at the ANA, whether you're doing it by ELISA and immunofluorescence. You look at the pattern that would help you in knowing what is the classic pattern that you're seeing in ANA, but then after that, you go to checking any one of those antibodies, and if you have any of them, then that tells you that this patient most likely has Sjogren's. Now, if we have all those antibodies, do we need a salivary gland biopsy? Let's say a patient is seropositive with classical symptoms. Is the salivary gland biopsy mandatory? Now, we know there are several ways to check a salivary gland biopsy. You can take a minor salivary gland biopsy, that is from the labial area, and make sure it's an untraumatized part. There is an ultrasound-guided biopsy, and then there is the simple biopsy that they take blindly by experienced surgeons. And this is what you look for. You don't want to look for a normal tissue that is on the left side, but you want to look for a lymphocytic infiltrates and assess the focus score. The problems with that? Well, it can be normally present in about 6 to 9% of the population. It can be falsely negative in 18 to 40% of Sjogren's patients. The sensitivity isn't really that great, although you might have a good specificity. Okay, the issues with the salivary gland biopsy. The problem that most of pathologists tell you that there is not enough tissue. Because simply there is no standardization of the size of tissue that you need to take. And even if you get to catch 4 glands in that biopsy, the distribution of inflammatory cells is uneven to the extent that you might not end up with a diagnosis asking for another biopsy, which is actually disturbing to the patients. The more tissue you ask for, the more surgical risk the procedure has. And again, after you do all that, then you need an expert histopathologist to read the sample. And in fact, Bayer has published that after revision of around 50 slides, 12 of them has revised diagnosis. So there is still a margin of whether we're having a right or the wrong diagnosis from the biopsy. It is not free of complications. The larger the incision, the more the complication. And in fact, the most common side effect that is reported by patient is lip numbness or hypersensitivity that is reported in up to 11%. And then you have the local problems, which are the inflammation, hematomas, granulomas, and the scarring and keloid formation. In fact, the thing about the salivary biopsy is that the presence of the Zika symptoms and the positive serology can actually predict the findings in a biopsy. So in a way, you might think there is no much additional benefit of a salivary gland biopsy. If I have the symptoms, I have the objective evidence, and there is no autoantibodies. But there is still a role. The role of salivary gland biopsy is limited somehow in centers that do not have experience histopathologists. to cases where you have an inconclusive clinical findings, i.e. a borderline finding for objective evidence of dryness. Also patients who are negative for serology but still have classical symptoms, patients who have extraglandular involvements of Sjogren's, and then of course if you want to diagnose the most common association of Sjogren's that we're afraid of, which is the lymphoma, and it's of more importance in the pediatric population than the adult population in terms of diagnosis. We are now seeing reports about imaging being as specific and sensitive as the salivary gland biopsy. So in the future years, you might see it replacing that biopsy, but for now, we still depend on the biopsy. Now coming to the therapy of Sjogren's. I'm not going to talk about the cholinergic agents. We're going to talk about the new advances that has happened, i.e. the immunosuppressive therapies that we have been seeing developing over the last few years. Now what is the problem with the therapy of Sjogren's? The problem is you have the systemic activity of the disease and you have the symptoms of the disease. When they collect patients, most of them are patients of dryness. You don't see this population of an interstitial lung disease or interstitial nephritis. You don't see many neurological symptoms of Sjogren's in those studies. You're mainly seeing Zika symptoms. And we know that systemic activity correlates poorly to the patient's reported symptoms of dryness. The way they measure the outcome in each of these studies is basically one of those two. It is either an SSDI, which is a very complicated grading system, assessing all the antibodies, the biological evidence, i.e. hyperglobulinemia, and then the systemic manifestations of the disease. And then you have the SSPRI, which is the patient-reported outcome. Now, most of the studies tend to look for a change in the systemic activity. And if you look at the score of the systemic activity, it's not that easy to see any change in that. The problem, again, with the studies is that it also assess the outcome in terms of the patient-reported outcomes, and it has been disappointing specifically in that area. We know that there are targeting T cells or B cells in the different immune system, and we're still not sure what to target in Sjogren's syndrome. And these are the initial trials that were reported in Sjogren's. We had the studies of anti-TNFs, including etanercept and infliximab, and then we had the anakinra. We didn't have SSDI and SPRI as the outcomes. We had a 20% and 30% reduction of the symptoms. And the number of patients, although it was as low as 14 or as high as 100, all of them were actually disappointing. And then came the rituximab studies. After around 5 or more open-label studies, we had 4 randomized control studies looking at rituximab specifically with specific outcomes in Sjogren's. The most important study being the TEARS and the TRACT study that looked into specifically the improvement in the VAS. And if you see the results of those studies, although they did not meet the primary endpoint, you see that there was some improvement seen in rituximab in the earlier stages of the study, not in the late stages of the study. So one might think that maybe we should alter the dose of rituximab enough. That's one approach. But then after that, after the TRACT study, all those agents that you see in orange was actually studied in Sjogren's. So now it's gaining more interest. Somehow we might have a future for Sjogren's, so let's see. I'm not going to read all those drugs for now because that's going to be a tongue twister, but we're going to focus on some of them. And this is simply a summary of all the studies that you will find in rituximab. Those red dots are the failed studies. You can see that there are so many red dots, and some of them are actually just phase 2 trials. Now, what have we learned about rituximab in Sjogren's? We know that it works at the early time, that's 5 weeks and 12 weeks. We know that it does not really work at the end of the trial period, mainly at 24 and 48 weeks. It has no benefit in the tiered trials. However, the authors did submit a second analysis showing that maybe if they change the outcome, you will have benefit. They actually proposed a 30% improvement, and then when they did that, they actually found that actually it might be that rituximab works, but we didn't choose the right endpoint. It does improve the parotid histopathology and improves the texture of the parotid glands, and there is a transient decrease, not absence, of salivary gland B cells. We also saw the combination therapy trial in the ACR, and that's belimumab with rituximab. Now, this was a long-term study that included 3 arms. I'm sorry about the quality for those sitting in the back, but basically they looked at belimumab alone, rituximab, and the belimumab plus rituximab. The SSDI and the simulated salivary flow was actually improved. However, again, the patient-reported outcomes did not improve. The major improvement was actually reduction up to 0 in those salivary gland biopsies in the combination group. Inalumab, which actually works on B-cell differentiation, have been studies, and again, although we find evidence in the SSDI, we did not actually find evidence in the fatigue measures or in the patient-reported outcomes. We cannot talk about Sjogren's without talking about the necessity trial that included a combination of leflunomide and hydroxychloroquine. Again, not surprisingly, although the inflammatory burden of the disease, that is the SSDI, was reduced, the patient-reported outcomes were not met. And now, actually, the necessity trial is going on, adding patients with MMF and seeing if that is going to help with the outcome of patients of Sjogren syndrome. We're still waiting for the results of that. Two other agents, abatacept has been unfortunately not effective in Sjogren's. Iscalimumab is being studied in phase 2 trials, which is a proof of concept and might actually have some benefit in Sjogren's. The newer drugs, dazodalibep, which is actually studied as a CT40 blocker in so many diseases, might actually work in Sjogren's. In this study, they actually divided patients into those we will actually study in terms of SSDI, and then another population that was actually studied in terms of patient-reported outcomes. So we can compare changes in both arms. What happened is the SSDI score improved, SSPR reported outcomes has not much. Tocilizumab did not work, and then the JAK inhibitors was actually disappointing, but one new JAK inhibitor, which is remibrutinib, is being studied, showing that there is improvement at week 24. However, again, the patient-reported outcomes did not change much. Nipocalimab, which is an FSN receptor blocker, now what FSN does, it actually engulfs the IgG antibodies, prevents it from being redistributed to the circulation, and so it reduces the life cycle of IgG antibodies. It's still undergoing study. We're waiting for the results by the end of the year. Where those therapies fit, as of the EULAR guidelines recently, they're still called salvage therapies. None of them is actually FDA approved for the drug as well. So the take-home message is that antibodies have a diagnostic and prognostic role in Sjogren's. There is still room for salivary gland biopsy, but challenges do exist. Emerging therapeutic agents are multiple and promising, and the patient-reported outcomes are still challenges not met. Thank you.